Okay, so welcome again. We shall go ahead and complete the rest of chapter 8 here and hopefully chapter 9 as well. So we were talking about the bones of the forearm, radius and ulna. Remember, radius is lateral in the anatomical position, which means it's towards the outside, and then ulna is the medial bone, which is towards facing your body in that position again. So here we are looking at something called the carrying angle. And this is when you walk, and each person has their own unique gait, their way of walking. We hold our arms a certain way. Generally, in females, on an average, their arms, like their elbows are and their forearms, are tilted a little bit more away from the pelvis. Uh, and the reason for this being, women in general have broader, roomier uh, pelvic areas, obviously for childbirth and child support and so on. And therefore, so they tend to have this wider angle, right? So they're more like a pear-shaped body, so like a broader pelvis. So therefore, they have more of a carrying angle. And this is the reason why sometimes if you see a person coming from some distance and they're wearing like gender-neutral, sex-neutral clothing, you can usually tell if it's post-puberty, after puberty, that is if that is a male or a female, simply based on the carrying angle. If the body shape, of course, and what angle are the elbows making in relation to the pelvis, right? So they tend to have a more of a swaying gait as compared to an average typical male. Something else that we see here. Oh, all right. So we are down to the carpals and the metacarpals and the phalanges. And carpal region, carpus is your wrist. So we are looking at the wrist. And so as we can see, there are two rows of bones here. There's a proximal row, and then there's a distal row of bones that make up your carpal region. Okay, so what are those? And then again, we are looking. This is your um, your lateral side, right? Radius away from the midline, ulna is towards your body. So from medial to lateral, right? So let's see what we have here. The lateral most is the trapezium. Then we have the scaphoid. Then you have the lunate, right? And then we have the hamate here, right? So these bones. And then, so this is the proximal row. If you see here again, scaphoid, lunate, from lateral to medial, scaphoid, lunate, triquetrum, and pisiform. All right. And if you look at the distal row, the one which is farther away from the point of attachment, trapezium, trapezoid, capitate, and hamate. So there you go, trapezium, trapezoid, capitate, and hamate. This is your distal row, and there is your proximal one, right? As you can see here. Um, Scaphoid, lunate, triquetrum, and pisiform, the proximal region here, and this is the distal row of bones. Okay, so then you have these phalanges or your digits, right? Each phalanx, with the exception of uh, the thumb, basically has three different um, phalanges, as you can see. So this is your proximal phalanx, this is the middle phalanx, and this is the distal phalanx for all of your fingers, but the thumb has only a proximal and a distal phalanx, okay? There is no middle phalanx there. So like if you're double jointed, you can see in your fingers, you can have like these, you have the proximal interphalangeal joint and the distal interphalangeal joint. In your thumb, you only have a single joint here, something else that becomes clear in the picture. Scaphoid fractures. So these usually happen when you fall on an outstretched hand, like bicycling, and you lose your balance and you fall on an outstretched hand. Here's your scaphoid, just to give you a visual idea of where it is. And the thing with the scaphoid fractures is they're hard to detect. They don't really show up all that well on x-rays, okay? They could be pretty hard to diagnose early on at least, but the thing is that here you're at a far greater risk for something called avascular necrosis, which means breakdown of the bone as a result of lack of blood supply, okay? So this is not only the most commonly fractured, but also one that is at a high risk for avascular necrosis, as you can see here, okay? And so the healing time is quite long here. So you might have someone with a fractured scaphoid bone and they are like having to wear splints and things like that for long periods of time. And then eventually it will heal, but it's like a painful, protracted healing. Difference between the anatomical and the surgical neck of the humerus. The anatomical neck is located just below the head of the humerus. The surgical neck is a little distal to it. That's the point where the axillary nerve passes close to the bone. What features on the humerus articulate with the radius and the ulna? The distal and the medial epicondyles, all right? Or the trochlea and the capitulum. Those are the two regions. Trochlea with the radius and capitulum with the ulna on the medial side. What are some bony features that the radius and ulna share? They both have like a head, they have a shaft, what we call the diaphysis, a proximal end and a distal end. Describe how the radius and ulna are positioned when the forearm is pronated. Again, remember, prone is palm down, right? So what does it look like? Just take a look here. Here's your ulna, here's your radius, right? List the 8 carpal bones. We looked at those: scaphoid, triquetrum, pisiform in the proximal, and then the capitate and the hamate in the distal row. Which of these bones may be prone to developing avascular necrosis if fractured? That would be your scaphoid bone. All right, so here we are down to your hip region or the pelvis, okay? And so for that, let's go ahead and take a look here. This is your pelvic region. And so you see that there's 2 parts to it. There's a right pelvic region, and then there's the left pelvic bones. Each one is made up of 3 different bony regions. This is called your ilium right here. This is the ischium right here, and this is the pubis. So pubis, ischium, and ilium. So right away, it's quite obvious that your sit bones, if you will, are the ischium, the ischial tuberosities to be specific, right? So you sit here. The pubic symphysis is where basically your 2 hip joints or hip bones, also called os coxa, os for bone, cox, your hip region. They come together. In females, this joint it's made up of fibrocartilage. Another thing to remember, fibrocartilaginous joint here. In females, it becomes quite mobile during pregnancy under the influence of the pregnancy hormone progesterone. Because of childbirth, it's easier. The coccyx, the tailbone in the back, then you have the sacrum, right? You see that as well. This is your iliac crest. So this is your love handles region, right? So if you're dancing with someone and they're holding on to your the love handles region, it's basically the iliac crest that you can see here, all right? So this gives you a visual idea of what your os coxa, your bone, hip bone looks like, okay? So here you're looking at the right os coxa, the ilium, right? This is your iliac crest right there. Anterior iliac spine, posterior iliac spine, you see all of them there as well. Here is your ischial tuberosity, your sit bone, if you will, you sit on here, right? And this is the pubic tubercle in the front. This is the pubis. Over here is this depression called the acetabulum. And the acetabulum, you can see it's nicely rounded. So the head of the femur, your thigh bone, actually fits in here, okay? So that gives you an idea of what that looks like. Now you're taking a medial look, a medial view of the same right os coxal bone. So same things here. This is the iliac crest, anterior iliac spine, posterior iliac spine, right? You have something called the arcuate line as well, which is only visible posteriorly in the back. Here's your pubis, here's your ischium, the sit bones. So you see all of those here. Okay, so in this slide, we are looking at a distinction between what is called the true pelvis versus what was the false pelvis, okay? What's the difference? So the true pelvis is in this purplish color, and then the false pelvis is in this dark green region here, okay? So as you can see, the true pelvis extends from your pubic tubercle all the way back to your base of your coccyx, right there, okay? Everything underneath here is your true pelvis, and everything above there, which includes your ilium, mostly the iliac region, is the false pelvis. So what's the difference physiologically between, or even anatomically, between the true and the false pelvis? The true pelvis contains your reproductive organs, testes and ovaries, and also urinary bladder, while your false pelvis contains your colon, your large intestine. Okay. In this picture, we are looking at the difference between the pelvic inlet and the pelvic outlet. What is the pelvic inlet? Pelvic inlet is in blue right here. Pelvic outlet is right about here, the mouth to your pelvis. And this is also a nice comparison between your male and female pelvises. Look at the difference. The female pelvis is much broader. You can see that, right? The male pelvis is much narrower. Uh, the coccyx is less curved in females. It's more curved in males, okay? And all of those account for more room, more space in the female pelvis for accommodating a child, right? Uh, but possibly the best way of identifying whether you're looking at a male or a female pelvis is to focus here. This is called your subpubic angle. Look at the pubic angle or the subpubic angle in a male and look at the subpubic angle in a female. The male subpubic angle is acute, less than 90 degrees. It's kind of like a steep angle, not much space there. The female subpubic angle is obtuse, which means it's greater than 90 degrees. A lot of space here. And then, of course, you have pubic symphysis, that fibrocartilaginous joint on both ends. So a much broader pelvic outlet in females for childbirth again. And you can see how that difference is quite obvious in the subpubic angle, okay? So yeah, determining the sex of the skeleton, you're going to look at the skull. We talked about more prominent eyebrow, superciliary ridges in males and the more massive jaws and stuff. It's even more clear in the pelvis. If you look at the pelvis, males have a much broader one, males have a more narrow one, females have a much broader one. And if you look at the subpubic angle, that's quite obvious, right? It's greater than 90 degrees in females, less than 90 degrees in males. So the three bones that fuse to form the os coxae, ilium, ischium, and pubis. We just took a look at those. Where are the ischial tuberosities located? Just sit on a hard surface, and that is where they're located at. So they're also called sit bones. Function, they help you sit. How is the pelvic inlet distinguished from the pelvic outlet? Pelvic inlet contains your reproductive glands, organs, as well as the urinary bladder. The pelvic outlet contains your colon. Male and female pelvises, they differ with respect to the subpubic angle, greater than 90 degrees in females, less than 90 degrees in males. All right, next up, we are looking at the largest bone in the human body, which is the femur or the thigh bone. Right, so for the femur, the thing to remember again is that is your thigh bone, the strongest, largest bone in the human body. And so looking at the anatomy of that bone, here it is. And so now you can compare it with the humerus, which was your upper arm bone, right? And the differences here are quite apparent. As you can see, it's much larger, much thicker. And if you look at the head here, the head of the humerus, it is quite delineated, right? It's like a nice rounded sphere. There's quite a noticeable neck. You won't find this kind of an... Sorry about that. I didn't realize my mouthpiece was not in place. So yes, if you look at the differences between the femur and the humerus, nice rounded head, much more prominent than the humerus, much larger bone that the femur is. The neck is very much more pronounced. You have a greater trochanter here and something called the lesser trochanter. And these bony projections are for the muscle attachments of your pelvis, okay? Something to remember. Then of course the shaft itself, okay? And then if you look at the distal, so this is the proximal end, the head of the femur fits into the acetabulum, right? It's like a ball and socket joint. That's what they're called. And at the distal end, anteriorly in the front, you have a lateral condyle and a medial condyle. The lateral condyle will articulate with the fibula, which is your lateral bone of the lower leg. And then the medial condyle will articulate with your tibia, which is the medial bone of the lower leg. Here is your femur in a posterior view, as you can see. And what you see here is one single deep fossa, a depression called the intercondylar fossa, okay? So if you look here, that will help you differentiate the anterior end from the posterior. The distal region is where you have to look. All right, so next up you have your kneecap, also called the patella, as you can see here. So the patella is also one of those bones that does not articulate with any other bone. All it does is it's suspended in your tendon of your quadriceps muscles, okay? The front of your thigh. Those muscles, their tendon is where the patella is suspended in. It does not attach or articulate with any other bone, all right? This is the front or the anterior view of the patella. This is the back where you have this articular surface and this cartilage. That'll help you differentiate, okay? Okay, so down to the two bones of your of your lower leg, right? And those again are the tibia and the fibula. The tibia is medial in the anatomical position uh, towards the midline, and the fibula is the lateral bone. The fibula is also called your splint bone because it's kind of like delicate, and its main function is to give support to the tibia, which is your shin bone, much stouter here, right? Okay, so what we have here is the lateral and the medial condyle towards the head, the proximal end of the tibia, and they articulate with the lateral and the medial condyles of the femur, okay? And then moving down here, this is the shaft of the bone. This is the distal end. And so you have a medial malleolus here, all right? So the medial malleolus is what you can feel on your foot. This bone that sticks out on your foot on the medial side is formed by the tibia, the medial malleolus. Moving on to the fibula here. This is the head of the fibula, very delicate bone, as you can see, therefore called the splint bone of the lower leg. Here's the neck, as you can see, right? And then the shaft of the fibula, and then finally the lateral malleolus, which forms the lateral projection. So if you look at your foot, the bone that sticks out laterally down there, that is your lateral malleolus, and that is formed by the fibula, okay? Both the tibia and the fibula are joined together again by means of an interosseous membrane, just like your radius and ulna did in your upper limb, okay? All right, so finally down here to the foot region, and your ankle joint here is called the tarsal region, okay? Just like you had the carpal region for the wrist, carpus, this is called the tarsal region. And again, you have these three bones. It has two rows, a proximal row and then a distal row. So the proximal bones here are the navicular, all right, the talus here, and then the calcaneus, which forms your heel. And then your distal row is made up of the medial cuneiform, the intermediate cuneiform, and the lateral cuneiform bones. These form the distal row, as you can see. Then again, same thing. You have the big toe, also called the helix, as you see here. The great toe has only what? Again, two phalanges, a proximal and a distal phalanx, and a single interphalangeal joint. The rest of the toes have three phalanges, proximal, a middle, and a distal one. And they have two joints too, proximal, and then a distal interphalangeal joint, okay? So you see the same picture here. All right, so the arches, which are uniquely arranged in the human foot, because as I mentioned before, the humans are the only species that walk upright on two legs, on 2 feet. So here you see the medial longitudinal arch all the way from the balls of your feet to the heel, like this, right? So the foot is not in contact like a flat foot. Some people have flat feet, right? That's a congenital anomaly. But in normal human foot, you will see a medial longitudinal arch. And what keeps it elevated is the muscle tone and the ligaments of the foot itself, okay? You can also see the heel bone, the calcaneus, the talus, and the navicular at the top, and then the metatarsals, and then this little sesamoid bone over there. So then you have the lateral longitudinal arch, which as you can see is not quite as high as the medial one, right? Nonetheless, you do have this slight raise, so your foot is not resting flat on the ground again. And finally, you have this transverse arch in the front, right over here, the balls of the feet. And so this is also there to prevent full contact with the ground and also to distribute your weight more evenly all across the human foot. So these are some of the pathologies of the foot that you can come across if you're working as a podiatrist. Then again, podiatrists are those medical specialists that deal with problems of the foot. And the most common patients that you will see as a podiatrist are those suffering from uncontrolled or poorly controlled diabetes because of diabetic foot ulcers, foot infections, all kinds of things. A fair number of patients that you see as a podiatrist and you get a consult on would be diabetics, okay? So bunions, bunion is a malformation where your big toe is curved too much inwards towards your little toe, right? And this can be because of tight, like wearing pointy shoes. It could be congenital. With aging, it becomes more, or with trauma to the foot, this can become more common as well. Usually there's no clinical, no treatment required there. Sometimes if it's like painful, you might look at like local creams, anesthetics, and those kinds of things. In worst case scenarios, surgery might be needed. Pes cavus, This is like something called a claw foot. Literally, your foot looks like a claw. Excessively high longitudinal arches. A claw foot, usually found in most common in twins because they're like cramped for space or a difficult labor. So the foot is kind of like the arches are arranged like that. And then what is called the club foot or Talipes equinivarus literally means horse foot. So here the feet are inverted and medially rotated like this. All right, this is the permanent posture of the feet. And this is again because of a difficult birth. So the child is passing through the birth canal and the feet are deformed because of that difficult passage. Pes planus or flat feet, here there are the medial longitudinal arch is flattened. So flat foot, it's like in contact with the ground. These people are more prone to things like sprains and strains and other problems of the foot, right? Metatarsal stress fracture, again, because of more common in runners, repetitive stress on that region. Greater and lesser trochanter are located on the proximal end of the femur and they provide for attachment of the pelvic muscles. Where does the patella articulate with the femur? The patella does not articulate with the femur. It's simply suspended in the tendon of the quadriceps muscles. What are some bony features that is similar or same between tibia and fibula? They both have a head, a proximal region, a distal region. They're both long bones with a shaft. What is the primary function of the tibia? It supports your femur. What are the 7 tarsal bones? What were they? The navicular, the talus, and then the calcaneus, and then the medial cuneiform, the lateral cuneiform, and the intermediate cuneiform bones. Why is it preferable to have an arched versus a flat foot? Because arched feet distribute the weight more evenly than flat feet. Okay, so your limbs start forming. This is some embryology that we're looking into in between 4 to 8 weeks of development, right? So here you can look at the development of the skeleton, how it happens, some of the limb malformations that you can come across, polydactyly, having multiple fingers, extra digits, 6 or 7. It's a genetic mutation that can give you that. Ectrodactyly, where you're missing some fingers, a digit by birth. Syndactyly, webbing, the fingers are webbed, joined together. And we had webbed fingers as I mentioned before. By 7 months of pregnancy is due to when apoptosis causes your feet, your fingers to separate out and your toes. Amelia is a complete absence of a limb. Phocomelia is a short or poorly formed limb. And this was a common condition back in the 1940s and 1950s because there was a drug called thalidomide, as you can see here, which was commonly prescribed for like nausea, morning sickness, those kinds of things. And what they didn't realize was that this was actually a teratogen. And teratogens are those substances which can cause birth defects. So these kids were born with like malformed, like lobster claw looking hands and feet. So this was a problem that was addressed later on. Now they do not prescribe thalidomide as a sleep aid or any of those other uses anymore. All right, so we are done with our chapter number 9 here, okay? And so let me see here.